Hello, everyone. We are so glad you joined us for another episode of the LymphaPress educational webinar series. We always love to bring you good content because knowledge is power, and the information that you get is empowering you to better serve your patients. So thank you for taking time out of your busy day to be with us. We are so excited, and I'm going to jump right in and introduce our presenter, who is Dr. Heather Hettrick. Her resume is so long and her accomplishments so vast, it could take up too much time to tell you all about what she does, but she is a professor in the physical therapy program at Nova Southeastern University in Fort Lauderdale, Florida. She's been a licensed physical therapist since 1995, received her PhD in physical therapy in 2003, and has dedicated her entire professional career to integumentary function, as well as wound, lymphedema, and burn management. There's so much more to your experience that you've brought to us today, Dr. Hettrick. We're so grateful for it. And I want to just do some housekeeping as well. First of all, we see you're still logging on. If you have questions for Dr. Hettrick, and I know you will, please put them in the Q&A. We will answer them at the end. Everybody always asks, can I get a recording of this? Because it's always so good. The answer is yes. You will get an email after today's webinar with the link to the presentation, which will be on the LymphaPress YouTube channel. And you can always subscribe to that so you get alerts whenever we add new videos. And with that, the topic of today's webinar is a compelling question. Is all edema lymphedema? And I am going to leave it to you now, Dr. Hettrick, to answer that question.
Well, thank you so much, Brenda, and I really appreciate the invite to be here today. And thanks to all of you for taking your lunch hour or wherever you are geographically, the time of day for you to spare an hour with us today. I hope you find this interesting. This is definitely a topic that I am very, very passionate about. And I hope after the presentation today, it helps you think a little bit differently about edema, lymphedema, and can help you better serve your patients. So with that, we'll get started. I want to talk a little bit about what is edema, because we kind of see this, think about it, encounter it all the time, but what really is edema? And with that, we'll go into reviewing the lymphatic system. We'll define lymphedema. We'll introduce what I call the VAIL concept, and I'll help you understand the role of the endothelial glycocalyx layer, because this has been a game changer in this area. And I'll help you appreciate how all edema is actually lymphatic fluid. Therefore, all edema actually is a lymphedema, but there is a continuum, and really what that means clinically. So let's start with what is edema. Well, simply stated, it's just swelling of the tissues, right, related to fluid. But the fluid is actually lymph. So all edema is lymphatic fluid. And as you can see in these two pictures, you kind of have a yellowy transudate looking fluid, or you have lymph with chylus. And that is really a lymph that contains emulsified fats or free fatty acids. And that actually comes from the digestive tract, where we have lacteals, which are considered lymphatic capillaries, that specifically absorb dietary fats in the villi of the small intestine. And so there's some interesting theories being put out there about maybe a lot of these conditions like IBS, irritable bowel syndrome, Crohn's, other digestive disorders may be a component of lymphatic dysfunction in the gut. But again, back to this slide, what is edema? It's really swelling of the tissues, but what I want you to start appreciating, and we'll explain why, is all of this fluid is actually lymphatic fluid. So when we have fluid that is picked up by the lymphatic system, once it enters those dermal lymphatic capillaries, it's called a lymphatic load. And that term was coined by Dr. Foldy out of Germany. So it's really everything is absorbed by the lymphatic capillaries and then transported by the lymphatic system. So really, this is a lot, right? It's all fluid. It's 50% of blood plasma, 50% or more of blood plasma proteins. It's lipids, byproducts of wound healing, of tissue healing, dead and senescent cells, various cancer cells, a whole host of different enzymes, white blood cells, and even bacteria, endotoxins, perfumes, dyes, and pollutants. Because you have to remember, our skin is our first line of defense, right? And so I always talk about it being like a suit of armor. And a suit of armor is very solid and very protective until you get a chink in your armor. That chink is a weak spot. And this is kind of what happens when we have compromised skin or integumentary dysfunction, is now our suit of armor is a little bit chinked. But in top of that, when we put things on our skin or put topicals or put lotions or creams or anything on our skin, about 60% of it can get absorbed through the skin and picked up by the lymphatic system. So just kind of be mindful about what you're putting on your skin or on your patient's or resident's skin. But when we have a high lymphatic load to the point where it just has nowhere to go but out, as you can see in this picture, that lymphatic load, because you can see what it consists of, is very caustic. So it can actually lead to a denudement or a chemical-like burn of the skin if it's not properly managed. And we call that lymphuria. So it's literally fluid leaking out of the tissues that is lymphatic fluid, and it's called lymphuria. So let's talk about the geography of edema. So again, it's everywhere, right? When we have edema of the feet, the ankles of the lower leg, we tend to call it peripheral edema. It can be called peripheral lymphedema when we are more consistently talking about the disease of lymphedema with respect to the extremities, the trunk, the genitals, or even the head and neck. Pulmonary edema involves the lungs. Cerebral edema involves the brain. Ascites is edema in the abdominal spaces. Anasarca is full body edema. And then there's an older term called third spacing, which is where fluid moves from that vascular system to spaces between the cells or body cavities that really normally contain little to no fluid. And then there's a term that some of you may be familiar with is puffy head bird leg syndrome. And this is actually what astronauts, or even our astro civilians, experience when they go into low Earth orbit or weightlessness, where they get a 2-liter fluid shift from the lower body that up to the trunk and the head due to that loss of gravity. So it's almost like an inverted venous insufficiency. So again, because of that loss of gravity. But what I want you to take home from this slide is that edema is named according to the location, and edema is the result of some type of etiology, but it is all lymphatic fluid. And as we go through this, this will make sense. So the causes, well, there's definitely well over 30 medical causes of edema or etiology of edema. However, all, again, are associated with the lymphatic system, as it is all lymphatic fluid. And you can see this list here. This is not all inclusive. However, it's some of the more common conditions that can lead to an edematous state at different parts of the body. So again, the cause of the edema may be different, but it is all lymphatic fluid. So I think you're familiar with this. When we grade edema, it's fairly subjective, right? But we do try to give something somewhat subjective, an objective way to document it. And so this is one method where you can try to grade the amount of pitting or the rebound time. So a grade 1 would be just a little indentation, barely visible, maybe 2 millimeters. Not that you would measure this, but it's an estimate. And the rebound time, meaning for that fluid to come back or that tissue to respond, would be immediate. So it's very quick. Grade 2, a little bit deeper of a depression, a slight indentation. It may take 15 seconds or less for that rebound to occur. All the way to a grade 4, where it's a pretty deep indentation, and it will take more than 20 seconds for that tissue to return to its normal state. And this is important because this helps discern potentially the etiology behind the edema, but also, are we moving towards or a progressive state of the disease of lymphedema? So it's important to try to quantify the edema when it's present and to document that accordingly. So when we're grading this edema, when you get a rebound, which again would be a 4, when a rebound is greater than 30 seconds, and that's really a long time if you sit to think about it, this is indicative of the disease of lymphedema. And currently, as you know, we do not have a cure for lymphedema, although we may see one in our lifetime, but is also a progressive condition. So when it takes longer than 30 seconds, it is indicative of the disease of lymphedema, and we'll talk about why. Now, hard and non-compressible tissue is indicative of lymphedema due to the fibrotic changes that are induced by this chronic inflammatory state. And that's really the why. So to understand that and appreciate that in more detail, let's do a little review of the lymphatic system. And I like this way it's described. So when you think of the lymphatic system, think of it as a nodal centric immunovascular system. And it's like, okay, that's a lot, but let's break this down. Nodal centric, meaning all that fluid is getting picked up by the lymphatic vessels and transported to regional lymph nodes where it's cleansed and processed so it can be reintroduced into the venous system up at that venous angle, up at the connection of the internal jugular and the subclavian, right? It's also an immunovascular system because this system is responsible for not only managing the interstitial fluid environment, but it mediates immunity and inflammation. And so as you can see on that picture on the left, we see our traditional veins and our arteries as that closed system related to the cardiovascular system. And the green is representing the connection and the interconnection that that lymphatic system has with our vascular system. So we have to stop the siloed approach to understanding the body systems because they're all interconnected. And I'm going to talk about that shortly when we get to the VAIL. But I want you to appreciate the connection that the lymphatic system has in particular to the venous system. And with that, Dr. Stanley Roxon out of Stanford, who is one of the leading lymphologists probably in the world, if definitely not in the United States. I love his analogy because he talks about a healthy lymphatic system is like the mortar of a brick wall, right? You've got a very solid wall. It has good integrity. But when your mortar is not good or it can't stand the test of time, or there's problems with the mortar, your wall is not going to be very effective or very stable or functional. And so I think it's important to consider that because the lymphatics are so significant and so important with the overall health of our body. And yet so little is really taught about this system in traditional medical schools or other programs. So it's really a disservice. We need to be teaching more about the importance of this system and this and how vital it is to human health. So let's talk a little bit about the lymphatic system being the body's drainage system. So I love analogies, so just bear with me. So here you can see a water processing plant. So the pipes are, as you can see on the top, are kind of analogous to those deep lymph collectors. The water filtration pods, as you can see on the bottom left, are analogous to the lymph nodes and somewhat look a little bit like lymph nodes, especially if you stretch your imagination a little bit. But the goal of both of those is really purification. So when you look at a picture, a cross section of the skin, and I really like this because at the top up here, it's showing you the epidermis dermis, and this little circle is a cutout of what's showing you over here on the right. And you can see these tree-like structures, right? Now these are housed in the dermis, which is only 3 millimeters deep. These are your dermal lymphatic capillaries, and they're everywhere. And they're also what's considered bidirectional, meaning they can open, as you can see in their orientation, and pick up fluid from any orientation. As they pick up that fluid, they transport it down to what these tree trunks kind of look like, are called pre-collectors. And these pre-collectors take all that fluid from the lymphatic load that it's getting picked up, down to these deep collectors. And these deep collectors are valved structures, much like our veins, but they run parallel to the deep arteries and veins just around the level of the fascia. And so that's really our vessel systems. So what this is like, if you can envision a neighborhood or an apartment complex or whatever, your neighborhood, those lymphatic capillaries are kind of like the bathrooms, right? They're picking up all the waste products. And as things get flushed, they go down the pre-collectors or the housing sewer system to the city sewer system, right out in the street, which are the pre-collectors, or down the pre-collectors to the collectors. And that ultimately is going to take it to this water treatment plant over here, where that fluid is going to get cleansed and processed by the lymph nodes. So I like this analogy because I think it helps you appreciate the concept of what the lymphatic system does and the importance of why these structures are so vital and what they really do, because these are the structures, the lymphatic capillaries, the dermal capillaries up here, the pre-collectors and the collectors, combined with the lymph nodes that are responsible for all the fluid homeostasis. We'll talk about that. So our classic understanding of the functions of the lymphatic system, we know it provides fluid and protein balance. Again, proteins are really large macromolecules. So when they escape into the interstitial spaces, they can't really re-enter. And that's what one of the job of the lymphatic system is, to pick up those larger macromolecules. We also know fat absorption from the intestinal tract is a role and responsibility of the lymphatic system. I showed you that almost on the third slide. And we also know it does a great job at an immune response to infectious agents or organisms. And in fact, that bottom picture here, where you can see this orange little structure, that's a Langerhans cell. And the Langerhans cells actually reside in our epidermis, and they kind of hang out, warding off that initial defense, right? So if an organism comes into our skin or something's there that the body identifies as a threat, these Langerhans cells are going to be our first line of defense, part of the lymphatic system that is going to attack that structure, that microbe, whatever it is, and get it processed and taken to the lymphatic system to be handled. So this is initially how we help, the lymphatic system helps clean the interstitial fluid, but also provides that blockade to the spread of infection and even malignant cells. We have some newer understanding now, though, of the function of the lymphatic system. We know it plays a role in reverse cholesterol transport. It has an indirect regulation of brain function via the cerebral lymphatics and the glymphatics. And this is a huge area of research going on now, which is absolutely fascinating. And some of the problems that our astronauts and astro civilians are experiencing is due to some of the dysregulation when they go to weightlessness that happens due to the lymphatics up there not having any contractibility because there's no muscles in the brain. And interestingly, more recently, they have found that it also helps to impart some significance to organ growth or repair, particularly cardiomyocytes and even hair follicles. So the answer to baldness or alopecia may reside somehow with lymphatic dysfunction dysregulation. So stay tuned for that. We'll know more as we learn more. So the lymphatic system, again, reacts to an increase in lymphatic load. So the more fluid that is present, it can increase how much it can transport. It's called that it can increase its lymph time volume. So as more lymph enters the lymphatics, it causes an increase in the contraction frequency of the lymphangions, which are those valved sections of your lymph collectors. Now, under normal physiologic conditions, the transport capacity of the lymphatic system is much higher than the actual lymphatic load. So we have a safety valve built into that, which is great. And this is why, we don't walk around being edematous all the time. If the lymphatic load, however, exceeds the transport capacity of a healthy lymphatic system, fluid will accumulate in the interstitial tissues, causing an edema. This is what we know as a dynamic insufficiency. And this is really a symptom of something else that might be going on. So for example, it might be an ankle sprain. This might be congestive heart failure. It might be chronic venous insufficiency disease, a whole host of other things, medication-induced edema. These are all forms of a dynamic insufficiency. So again, the appropriate therapeutic approach when we have a dynamic insufficiency or an edema here is, RICE, rest, ice, compression, and elevation, and it's typically transient and will resolve. However, mechanical insufficiency is actually when there is trauma or surgery, maybe radiation, infection. There could be valve or mural insufficiency. So the walls of the vessels of the lymphatics could be malfunctioning or malformed. And other problems can lead to a mechanical insufficiency. And mechanical insufficiency is actually what causes the disease of lymphedema. So here, the lymphatic system is diseased or injured, and its transport capacity is not able to cope even with the normal amount of lymphatic load. So you can imagine anytime that body area or that area is stressed and the lymphatic load increases beyond what's normal, this is where our patients with lymphedema end up with a lot of compromise and some exacerbation. So it becomes a very vicious cycle. So lymphedema as a disease, let's talk about that. Most pathologies associated with the lymphatic system result in some type of edema or lymphedema, right? That's the clinical manifestation that's telling us, it's our visual biomarker, right? That there's some pathology going on with the lymphatic system. The disease of lymphedema is currently a chronic incurable condition that is characterized by an abnormal collection of protein-rich fluid, and that's going to become important as a result of some anatomical alteration to the lymphatic system. This can lead to significant impairments in the person's function, their ADLs, activities of daily living. It can lead to significant skin disorders, discomfort, and a lot of psychosocial issues as well. And you can imagine, just looking at these pictures, what a burden that can be to carry around a lot of that extra fluid at any given day. So again, we're talking about lymphedema as a disease right now. So as a disease, it can be primary, where somebody may be born with a congenital malfunction or malformation of the lymphatic system, or it could be secondary, where it's acquired later in life. Typically, regardless if it's primary or secondary, it's going to involve the extremities, but it can also include the trunk, the genitals, and even other body locations. So it's really important when you're assessing, as you look comprehensively at the patient. For your lower extremity lymphedema patients, it's really important to ask in a professional way if they're experiencing lymphedema or swelling of the genitals, men or women, because it's not always something that they're going to volunteer, but it's treatable. It's something we can manage, and we can teach them how to manage that. So very important to ask. It's not just usually reserved just to the leg or just to the arms. There's usually other body parts that are involved. And one unique characteristic of the disease of lymphedema is that if it is a bilateral presentation, it's always going to be asymmetrical. And the way we know that, sometimes it's hard to tell by looking at it, but you should know that by your girth measurements or your circumferential measurements. And you want to take that to get a baseline, even if there's bilateral involvement, to get a baseline, and then to use that to monitor how the patient is doing after therapy has been introduced. So let's talk about this edema versus lymphedema, and all edema being lymphatic fluid, because I'm going to get into some of the physiology shortly. And I promise, I hope it won't be too dry for you. But we know edema is the abnormal excess of accumulation of serous fluid in the connective tissues. Go back thinking about that ankle sprain. In this situation, the lymphatic system is temporarily overwhelmed. So it's a lymphatic insufficiency, but it's not permanently damaged, right? So there's a trauma, there's an ankle sprain, the body's going to mount a response to that trauma. You're going to get an inflammatory response. Fluid is going to be released into that area, as well as a whole bunch of other products and chemical mediators to help mitigate that trauma, right? So this is a lymphedema, but it's a lymphatic insufficiency. It's temporary, it's transient. That is very different than lymphedema, which is an accumulation of protein-rich fluid in an extremity or body part that is due to damage or loss. So now we're talking about true lymphatic impairment to some part of that lymphatic system. And again, remember, this can be a congenital issue, or it can be something that developed later in life. But the case that's different here is this is really a protein-rich edema, which we'll talk about. Leading to a progressive and permanent impairment. And what's interesting, which you have to appreciate, when we talk about a watery edema, you can think about like congestive heart failure edema, where it's very easy to displace, very easy to manipulate. It's kind of like dough, bread dough or pizza dough, right? When we're talking about protein-rich edema, it's viscous. So it feels kind of like honey in a Ziploc bag. So it's slow moving. And anyway, that's just one way to kind of appreciate it. And that actually speaks to some of our interventions, because our techniques, our manual techniques, have to be done very slow and rhythmically to allow that viscous fluid to be able to be mobilized. So it's because it's not watery like a regular quote unquote edema. So another way to look at it, because I love analogies, is let's think that, your healthy lymphatic system is like a pickup truck. It has a great transport capacity, and it can haul a lot at any given time. But what happens if for some reason you don't have your pickup truck that day for whatever reason, and you're driving a smaller car, that smaller car still has a transport capacity, right? But it's going to have to take a lot more trips and it's going to have to work a lot harder. So this is kind of what happens when we have an injury or post-operative edema or congestive heart failure. The transport capacity is still there. It's still functional. It's just compromised. It's overwhelmed. So this is really most edemas, right? Those transient type of edemas. But remember, all edema is lymphatic fluid. So this is actually semantically a lymphedema, but it's a transient lymphedema. This is not the disease of lymphedema. However, if you have that smaller car and that smaller car gets in an accident or is damaged, now you have a permanently damaged system that no longer can sustain a normal transport capacity. This is what happens when we have a permanently damaged or diseased lymphatic system. This is now the disease of lymphedema because the transport capacity is just not there. So hopefully this analogy can help you appreciate that and put it into a little bit more context. So you might be asking yourself, okay, well, that makes sense, but if this is all just swelling, if you're telling me the disease of lymphedema is really edema, why does this happen to the skin? Great question. So let's explain that, because this is telltale for lymphedema. You're not going to see this in other conditions. And what I want you to note is that picture on the right here, where she's doing her pitting test, right? Her edema assessment. You can see there's very little pitting happening in her lower finger, where this tissue is very hard and fibrotic and non-compressible, compared to up here where the tissue is softer and more pliable. So I want you to just keep this picture in mind as we go through the next few slides. So I'm going to introduce you to the concept of the VAIL. The venous, V, arterial, A, I, integumentary, and L, lymphatic systems are interrelated. So anatomically, physiologically, and biochemically, these systems really work in unison to maintain homeostasis. Dysfunction in one system will lead or can lead to dysfunction in the other systems, and this can manifest subclinically or it can be overt and really obvious in clinical practice. So again, appreciating the VAIL. I love this picture. Now, this is actually of a chick embryo, but the anatomical orientation is the same in all mammals, where you have an artery here labeled A, you have a vein here labeled with the V, and all this webbing or translucent material around it are our dermal lymphatic capillaries. And you can just appreciate from this picture that interconnection, right? And in fact, we know that the lymphatics are actually developed during gestation out of the venous system. I believe it's the deep cephalic vein. Don't quote me on that. But the system is actually sprouts literally from the venous system. And I think you can sort of appreciate by looking at this picture how when there's compromise in one of these systems, it could potentially lead to compromise in the other systems. So we know edema is the clinical manifestation of either an overwhelmed or damaged lymphatic system, right? Think of your pickup truck versus your smaller car, or your ankle sprain versus your true lymphedema. One is transient and the other is a disease, but both are part of this lymphedema continuum because all edema is lymphatic fluid. We also know lymphatic impairment leads to local areas of compromised skin and renders that skin barrier function more prone or susceptible to breakdown and impairments such as chronic wounds or infection. And this is called lymphatic dermopathy. And a great article to me that was just a game changer was this one down here by Carlson, and it's referenced for you. And he talks about when there's disruption to the lymphatics locally, it creates a local cutaneous disruption as well. And this is kind of explains why with patients with chronic venous disease, we see so many associated skin impairments, right? It's not just the venous disease, it's lymphatic dermopathy as well. We also know that movement enhances the VAIL to provide more optimal functioning because it enhances the muscle pump. It enhances the pumping of nodes, which are beautifully placed in areas that are compressed with movement. And it also supports just the overall health of our vascular system. So again, the venous and lymphatic systems are mutually interdependent. When dysfunctional, the result is a dual outflow system failure. And I'll go over this shortly. But so that just means there is compromised venous system, then a compromised lymphatic system. And if a venous ulcer develops or there's skin disruption that develops, now we have a tri-system failure because now we have integumentary dysfunction as well. So again, this is the second bullet cites the evidence that came out of that Carlson article that disorders of the lymph system, whether they're systemic or localized, produce these cutaneous regions susceptible to infection, inflammation, and even carcinogenic changes. And that's important because sometimes these chronic wounds that have been around for years or months and are just not progressing, they could have carcinogenic changes. So get a biopsy, don't wait. If you can't do the biopsy yourself, refer for a biopsy, but a lot of times you'll find that squamous cancerous changes may be present, and until that is treated, that wound is not going to progress. We also know that the pathophysiology of lymphedema or stagnated lymphatic fluid explains the propensity for infections such as cellulitis and those hypersensitivity reactions we see in our patients with chronic venous insufficiency. Again, that speaks to that lymphatic dermopathy. And we know that a functional lymphatic system is essential to an organism's overall health, given its role not just in fluid homeostasis, but the removal of cellular debris and the fact that it helps to mediate immunity and inflammation. So think about all those conditions that have an immune issue or an inflammatory issue, right? So lymph stasis is very problematic because it leads to this chronic inflammatory state, which is not healthy. So lymphedema, the disease of lymphedema, is a chronic inflammatory state. And what happens is when we have stagnating lymph that's just hanging out in the tissues, not getting picked up properly because there's dysfunction, it can result in a pathohistological state of chronic inflammation, which creates this whole cascade of macrophages and fibroblasts wreaking havoc internally in the dermis, creating this fibrotic tissue changes. We get that thickening and connective tissue proliferation like you saw in that picture when she was doing the pitting test, right? We also know that oxidation and degradation of interstitial proteins, when those proteins are hanging out and not getting picked up by the lymphatic system, it's like leaving milk or butter out in your kitchen. It's going to get rancid and break down. Same thing happens. And when those proteins break down in the tissues, it attracts monocytes that then become macrophages, and then they ingest proteins and activate more fibroblasts. And we end up with this whole cascade of collagen overproliferation happening. And we end up with that thickened dermis like you saw in that picture. Interestingly, it can also trigger adipocytes, which are our fat cells, which is an endocrine organ, and that can lead to a fatty tissue proliferation. So there's a connection that we'll talk about too with adipose tissue and fat disorders and even obesity. So again, what is this lymphedema continuum? Well, we've been alluding at it, but let's talk about the physiology behind it. There is no reabsorption in the blood capillaries. I know we've all learned that because of Starling's law, but again, there is no reabsorption in the blood capillaries. Fluid is returned to the venous system or that vascular compartment by the lymphatics alone. So when I first heard this, I was like, what? So I want to break it down for you a little bit. And again, citing Dr. Roxon and Mortimer, they talk about and have published for a while now that it may be better to consider the presence of chronic edema as synonymous with the presence of lymphedema, inasmuch all edema represents relative lymphatic drainage failure. Again, this is where all edema is lymphatic fluid. So again, the etiology is important, right? And the location is important, but it's all lymphatic fluid. But what we have to appreciate is whether it's a temporary or transient dysfunction of the system or a more permanent impairment, because that is the spectrum, that's the continuum. So how is all edema lymphedema? You know, you're probably thinking, well, what about Starling's principle of the microcirculation? Well, to do a quick review of Starling's law, we had all learned basically, and this has been dogma for hundreds of years now, that when you look at the capillary and you have that arterial end and you have that venule end, there is still hydrostatic pressure that forces fluid out of that blood capillary into those interstitial tissues. That's normal, and that happens. And that actually happens throughout the duration of that capillary. Starling basically proposed, however, that osmotic and oncotic tissue pressure actually helped push that fluid back into the capillary at the venular end, at the venous side of that capillary, and was purported stating that 90% of that fluid returned at the venous end and 10% was returned via the lymphatics. That was our traditional understanding of Starling's law. That is no longer the case. The only thing that holds true there is the thing about the hydrostatic pressure forcing that out at the arterial end. And I'm going to explain why. And our new understanding is centered around a structure which we've known about from the early 1940s, but only lately have had the technology to really see and appreciate, is called the endothelial glycocalyx layer, the EGL, or sometimes you'll hear it called the GCX, the glycocalyx. This is a gel-like matrix that surrounds all the lumens of the vessels of the body. And attached to that gel-like matrix are these hair-like projections which extend into the lumen of the capillary. And it acts as a molecular sieve, and it regulates macromolecule movement and fluid movement across that capillary wall. And what we know is that there's now only a diminishing net filtration across that capillary bed. So the capillary up here has higher pressure, so a lot of fluid is coming out of here, but it's still coming out all the way down, but not really, there's nothing coming back in because the endothelial glycocalyx layer mitigates that and controls that. We've also, not we, but Levick and Michael have proven this mathematically, that there is this no reabsorption happening in that capillary. And they have found that there's only this diminishing net filtration across that capillary bed. So this is really helping us to understand our new understanding of fluid exchange. So this EGL, this endothelial glycocalyx layer, is very well organized, and it responds to blood flow shear forces. So fluid, blood, macromolecules moving through the lumen of those vessels actually creates, through mechanotransduction, signaling that stimulates those endothelial cells. Remember where that gel-like matrix lines? And these vascular endothelial cells respond to these mechanical signals and produce and release nitric oxide, which dilates the vessel. That allows for more fluid and more macromolecules to escape. Now, the EGL can shed, like a dog sheds its fur, in response to inflammation, ischemia, sepsis, trauma, atherosclerosis, diabetes. Think about fluid management, particularly with burn, fluid resuscitation, as well as prolonged immobility. So that's again, not an all-inclusive list, but a lot of times when that EGL is shedding. Now, shedding is conceptualized, like I said, like a dog shedding its fur, and it does that during inflammatory states or disease states. And this allows more fluid to escape through that EGL. But clinically, what we see is edema or swelling. And so when you see that, you know that area of that EGL and that body area has been disrupted. Now, usually in a healthier individual, the EGL can repair itself in about 2 weeks, but sometimes it takes a lot longer or it's compromised. And this is just a very important concept to understand. We also know, again, that the dense capsular design of the lymph nodes, the fact that they're located in joint areas that are constantly mechanically compressed by movement, and the role of the EGL all work synergistically to help facilitate that fluid reabsorption by the lymphatic system back into the venous system, but it does this exclusively through the lymphatics. But think about those patients that are immobile, or maybe they have a splint or a brace or an orthotic that limits their joint range of motion. Maybe they've had lymph node removal, or they have venous hypertension. All of those conditions, again, not all inclusive, can have a significant impact on fluid retention in the dermis and subcutaneous tissues. And we know the only way for that fluid to be transported or removed is by the lymphatics, and it's done by the lymphatic capillaries as well as the capillaries by the lymphatic nodes or within the lymphatic nodes. So super important to understand that all fluids, proteins, and macromolecules are removed from that interstitium by the lymphatics and the lymphatics alone. And basically it's taken to those regional lymph nodes to be cleansed and processed like I showed you at that water processing plant. So we know there are a lot of risk factors for lymphedema, right? Again, not an all-inclusive list. The take home with this is to always try to modify risk factors whenever possible. But I want to focus on two of them. The first being obesity and the second being chronic venous insufficiency, because we see a tremendous amount of both of these conditions in our patient population. Not to diminish any of the other risk factors that are listed here, but I want you to appreciate the role that these two conditions actually have with respect to lymphedema. And here I'm talking about the disease of lymphedema. So there is definitely a link between obesity and lymphedema. Why? And it really comes down to adipokines. So adipose tissue, as you know, is an endocrine organ, and it produces a hormone called adipokinase. Too many adipokines actually can harm the lymphatics because it makes them leaky and it can negatively impact their ability to contract. So we're talking about the deeper lymphatic collectors, right? Because those are the contractile units of the lymphatic system. And over time, they just fatigue, they wear out. And also when we have a lot of stagnation or lymph stasis, so fluid that's not getting picked up in the interstitial spaces, it stimulates adipogenesis, creating a vicious cycle. So we know also that obese individuals on average, not all of them, suffer from greater immobility. Thereby they have a reduced muscle pump, which can further impair or impact their lymphatic function. And when we have patients with large pannus, like a large overhanging abdominal wall, it can not only compress the lymphatic structures, but it can really compress the venous structures in the pelvis, the abdomen, and in the upper leg as well. So there's a condition called OIL, obesity-induced lymphedema. And the take home is really obesity can cause lymphedema or worsen lymphedema. And there is a threshold of a BMI of about 40, at which point lower extremity lymphatic dysfunction can occur. So usually in patients with a BMI of 40 or greater, most of them have, if not a primary lymphedema, a secondary lymphedema. The risk of OIL increases with an elevated BMI. And some studies indicate that almost 90 to 100% of individuals with a BMI of greater than 60 have some form of a secondary lymphedema, again, the disease of lymphedema. Now, patients with OIL are at risk for the disease and are really best managed with weight loss, behavior modification, healthy lifestyle, those types of things. And they'll consider operative intervention to reduce extremity overgrowth only when patients have reduced their BMI to less than 40. But this requires a very committed medical team and patient adherence and involvement as well. So again, I think what happens is it gets missed in this patient population because people are so focused on the obesity or seeing the adipose tissue, but they're not recognizing that there's also lymphatic problems and fluid retention issues as well. So I also want to talk to you a little bit about CVI or chronic venous insufficiency, because that too is a huge risk factor. And we know that venous insufficiency is the result of increased venous hydrostatic pressures that are really caused by a series of disorders in the vein that really involves when the valves of the veins don't function properly, right? And so this can interfere with venous return and causes blood to pool in the veins. Now, since venous return is dependent upon proper functioning of valves, we need those valves to close and open to allow that fluid or the blood to return to the heart. But when they don't, we can get that venous backflow, that venous regurgitation. And when those valves don't function properly, it impairs or there's calf muscle pump function or impairment. We get valvular incompetence. There can be obstruction and dysfunction of the muscle pump. It can all lead to venous insufficiency. And this can be more chronic and lead to skin changes like we see, like spider veins, varicose veins, phlebitis, blood clots, different changes in the skin. The most serious being a venous leg ulcer, or VLU. So chronic venous disorders is just a collective term that we use to describe a long-standing condition involving impaired venous return of varying degrees of severity. And I think you're all familiar with a lot of the sequelae that can happen and the symptoms that can happen, but it really, again, results in regurgitation of blood in the veins, which impairs capillary function that leads to hypertension in those tissues. This creates a dermal backflow of lymphatic fluid, leading to a dual outflow system failure, because now we're talking about the veins as well as the lymphatics. And it's speaking really again to that lymphedema continuum. So this affects many, many people, but I think it's important to appreciate the interplay that this has between the veins and the lymphatic system. And it can even pull in the integumentary system when we start having skin disruption. And this has been shown through ICG, indocyanine green near infrared fluoroscopy studies, where here on the left, you can see a darker complected patient with hemosiderin staining, so classic signs of venous disease. They've injected the ICG, which becomes a lymphatic load. It's a protein, and it fluoresces under near infrared light. And what you can see is all this kind of congestion. That's dermal backflow of the lymphatic capillaries. We shouldn't see that. That's not normal. That's pathology. In a different patient here, somebody with venous disease, but also with a venous ulcer. Now, these little Band-Aid looking things are the injection sites. So they just cover those. Otherwise, they'd be really bright under the light. But what you can see is you, again, see dermal backflow around that wound. And so this is really kind of what explains that induration or edema around a wound. It's dermal backflow. It's lymphatic congestion. And then you can see what looks like really good uptake, right? It's like, oh, the lymphatics is coming up that ventral medial bundle. You shouldn't see this. This should go deep. It should be picked up by those dermal capillaries, drop down those pre-collectors to those deep collectors, which we shouldn't be able to see. So again, there's significant dysfunction here. And to add to that, there was great research done by Wandalo, and this was back in 92 or 96, where he found heme-containing proteins like oxyhemoglobin, hemoglobin, myoglobin, which lyse in the interstitial tissues when there's venous disease, right? Because that blood is pooling, the blood gets into the interstitial spaces, the hemoglobin breaks down, it releases iron, we get that inverted biological tattoo, right? The hemosiderin staining. Well, those heme-containing proteins have been demonstrated to suppress further lymphatic pumping function. So this reiterates that whole concept of the VAIL system and that interconnection, and it helps to explain that tri-system failure, because you have venous dysfunction, which leads to lymphatic dysfunction, which then collectively leads to integumentary dysfunction. So just looking at this more closely, we know that venous hypertension leads to chronic venous insufficiency, either due to venous valvular reflux or deep obstruction, which can happen in the superficial, the deep, or the perforators. We know inflammation caused by venous hypertension leads to injury and disruption of the glycocalyx. And this can result in a high filtration pressure, causing an increased fluid in the tissues, as you can start to see in this picture. And an increased lymphatic water load. And when that lymphatic transport capacity is exceeded by the water load, that's that state of low protein edema. So this is that lymphatic insufficiency, right? The system's overwhelmed. Now, constant lymphatic hypertension causes infiltration of lymph into the perilymphatic tissues, leading to that chronic inflammatory state. So we start to see fibrosclerosis, lymphangitis, we see further lymphatic damage. And concurrently, mechanical forces in the endothelium lead to excess nitric oxide production, which release vasoactive substances. We get extravasation of red blood cells, which degrade into fibrin and hemosiderin, again, leading to impaired lymphatic pumping mechanisms. So that connection just continues to proliferate. And then when you have an increase in lymphatic load that occurs with chronic venous insufficiency, it causes an increased pressure in the venous end of that capillary. This increases the volume load on the lymphatic system. Therefore, long-standing chronic venous insufficiency can cause lymph drainage problems and lymphatic damage, becoming phlebolymphedema. And this is very common in our obese patient population. So CVI and lymphedema are interrelated. We call it phlebolymphedema, because when either system is overburdened, it can lead to fatigue in the other system. And we're seeing this more and more in clinical practice. So if you're familiar with the SEEP classification, this is how we classify venous disease. And when you're at a C3 level or higher, that is considered a secondary lymphedema, or what we're calling a phlebolymphedema. So even though there may be not overt signs of edema in C4, C5, C6 as shown here, this is all phlebolymphedema. But one of the things I want to stress is even when you don't have visible signs of edema, this is your opportunity to start compression. Please do not wait for signs of edema to start compression. When you see those spider veins, the varicose veins, or just patients complaining of fatigue, really, really important to start them on compression and start them on compression early, because you can reduce and or potentially mitigate the progression. The other thing that I think is important to note is that foot or toe swelling is not required to make a diagnosis of lower extremity phlebital lymphedema. Sometimes the feet just aren't as affected as others, so just please keep that in mind as well. So if all edema is lymphedema, right, what do I do with it? Well, first we need to know the etiology or contributing factors for medical management. What is the geography of the swelling? What is the patient's vascular status? What is the patient's integumentary status, inclusive of sensation? What is their functional ability? What is their cognition like? So really, again, it's going back to our basics, doing a thorough history and physical related to the edema, determine if we're dealing with a lymphatic insufficiency, which is overwhelmed, or true lymphatic impairment, which is damage or the disease of lymphedema. From there, what we can do, if we determine it's a lymphatic insufficiency or a transient lymphedema, the standard of care is really rest, ice, compression, elevation, and patient education. And in time, it will normalize, right? So again, think of that ankle sprain if you like to have something in mind. When we determine maybe that it's true lymphatic impairment or the disease of lymphedema, whether congenital or acquired, this is where we implement complete decongestive therapy, which is the gold standard for lymphedema management. And this is inclusive and kind of in this order of skin and nail care, manual lymphatic drainage, compression, both for treatment and for maintenance, because it's different, exercise, and the importance here is while wearing compression, and lots of patient education. So lymphedema, as you're well aware, is best managed by CDT. It is delivered in 2 phases. Phase 1 is clinician driven, where we really work to decongest those areas involved with the lymphedema until there's a plateau. And there's a plateau doing your girth measurements after, if you have a few weeks of no decline, then they might have plateaued. And usually patients, when you start CDT, are going to get pretty rapid reduction in the beginning, usually in the first few weeks, anywhere from 20 to 40% reduction. But once that extremity has plateaued, then that is going to move into phase 2, which is patient driven. And this is maintenance for life, because remember, this is a disease currently without a cure. Now, both phases, involve all those things I just listed. But the difference is in phase 1, the clinician is doing this, versus in phase 2, the patient or their caregiver is going to be doing a modified version of this. Now, it is highly effective on all forms of edema, right? As all edema is the result of lymphatic failure to some degree. So you can use manual lymphatic drainage, which is different than lymphatic massage. Lymphatic massage is not therapeutic the way manual lymph drainage is for lymphedemas. They're very separate treatments and have different goals. But CDT or components of CDT, particularly manual lymphatic drainage and compression, can be used very successfully in various forms of edema. And this is some research that we've pulled together. Because all edema is lymphedema, the benefits of adding MLD to all forms of edema and surgical protocols has been shown to improve outcomes. So what I've done here is listed where some of the research has been done with like total knee replacements, orthopedic injuries, venous disease, neurological diseases, some autoimmune diseases, and others. And on the next couple slides, it gives you those references. So again, this will show you total knee replacements, references 1 through 3, correspond to total knees. So that's kind of how these 2 slides go. So I just want to include those for you, because you can start thinking about using some of these techniques on other patient populations. But it is important to consider if you're going to be treating true patients with lymphedema or the disease of lymphedema, I really encourage you to get certified. Certified lymphedema therapists have a very deep dive into the anatomy and physiology and how to customize treatments to obtain the best goals and outcomes for our patients. So to recap, the venous, arterial, integumentary, and lymphatic systems, again, think of it as the VAIL, are interrelated. Anatomically, anatomically, sorry, physiologically and biochemically, these systems work in unison to maintain homeostasis. Dysfunction in one system can lead to dysfunction in the other systems, and this can manifest either subclinically or overt. And it can be a dual or a tri-system failure, right? Whether you have venous involvement, lymphatic involvement, and or skin involvement. Now, all edema is lymphedema, given its role, given the role of the EGL, and because all edema is lymphatic fluid. That's what I think is the take home. So again, remember, all edema is lymphatic fluid. There might be different etiology behind the edema, but it's all lymphatic fluid. And what we have to determine is, are we dealing with a transient lymphatic insufficiency, which is temporary, or are we dealing with the disease of lymphedema, which is a permanent impairment or disease or damage to the lymphatic system, again, which can be congenital, they're born with this, or it can be acquired. So I hope that sheds some light on is all edema lymphedema. I am happy to entertain any questions. I think we ended a couple minutes early. I don't know.
Oh, you are amazing. First of all, my phone is blowing up and chat is blowing up with appreciation for what you've just delivered for us. And not just the breadth and brilliance of the information, but that you created analogies so that the therapists and the doctors out there can easily use those analogies when explaining to their patients. Similarly, we have many patients out there that are saying, I get it because of the analogies. So thank you for that. And we do have questions, Dr. Hettrick. So I'm going to go to them right now. And I also want to say to our audience, if you enjoyed this presentation and were wowed as we were by it, I'm putting in chat our Lymphedema Awareness Month calendar of events.
Great.
Click that link. You can sign up. We've got amazing people like Dr. Mark Moline, Karen Ashforth, Leslie Bell. Please join us throughout the month of March for so many things. But let's get to the questions because they're really good ones. First one from John Beckwith. John, thanks for being with us today. Isn't oncotic pressure still important?
Oh, great question. Yes, of course, oncotic is still important and still plays a role, but it really fundamentally comes down to the issue of what is actually picking up the fluid once it's in those interstitial spaces. Now, I'm not saying that 100% of all the fluid is exclusively picked up by the lymphatic system, but it's darn close to 100%, just because of the way that the EGL works synergistically with the lymphatic structures and the way that the lymphatic structures are developed. Now, there is some input by oncotic pressures and things along that line. Absolutely. So proteins can make a huge difference, but the problem is we can't let them stay behind for too long or stay in those tissues for too long, because that's what starts that cascade of that chronic inflammatory response, because they break down and they lyse. But yes, thank you for bringing that up. Oncotic pressure is important, but it doesn't have the role that we used to appreciate, like when we used to understand Starling's initial description of the microcirculation. It's kind of been a little superseded by the EGL or the endothelial glycocalyx.
So there was some interest in the point you made about the difference between lymphatic massage and manual lymph drainage. Can you specify how it differs?
Sure.
There's interest from our audience.
Yeah, great question. So, traditional massage, lymphatic massage or petrissage or effleurage, oftentimes, it can be deep. It can be very relaxing. We tend to use oils or lotions, and they're long strokes and a lot of different types of techniques. So lymphatic massage is something that a lot of massage therapists or healthcare providers can offer to help with detoxing. It does help to mobilize the lymph system. It does help to mobilize the fluid, but it's not therapeutic in a way like manual lymphatic drainage is. And the difference is, now I'm not saying it's not a therapy and it's not therapeutic, it is, but manual lymphatic drainage, and the reason why it's called MLD is that it's really not massage, it's a manual technique. And when you think about it, when I said that your lymphatic capillaries are in your dermis, they're 3 millimeters down. It's a thickness of the credit card. So our manual techniques are there to target those structures. So manual lymph drainage is the therapist's hand or the treatment person's hand, the healthcare provider's hand, touching the patient's skin without any oil, any lotions, anything like that, to engage that tissue, to get a stretch on that tissue. And what that does is the lymphatic capillaries are attached. Now they're one cell layer thin. They're attached to connective tissue in the body by anchoring filaments. And when we provide a mechanical traction, it stretches those anchoring filaments, right? It allows those endothelial cells to open up. And like I said, that lymphatic fluid's honey-like, it's viscous, it allows it to come in. So manual lymphatic drainage is really what we call it, is a stretch. So I'm stretching those lymphatic capillaries, I'm stretching on those anchoring filaments. And then what I'm going to do is direct it to where I want that fluid to go. I'm directing it towards healthier or more functional regions of lymphatics. But it's a slow technique and it's repeated like 3 to 5 times. So we call it a stretch and a direct, but it's done in a very specific anatomical orientation, understanding the anatomy and the layout of each individual's particular lymphatic structures. And it's very individualized technique. And we also consider it, I think of it like an analogy. I love analogies, as you know. Think of a car accident, like when you're driving on the freeway, right? Wherever that accident is, all the cars back up behind that accident. That's what's happening when we have lymphatic compromise, whether it's an ankle sprain, whether it's true impairment, all that fluid is collecting. So what manual lymph therapists do, we act like the police officers. We come in and we reroute that fluid. We reroute those cars around the accident. And it takes just the initial first cars to follow the orders or the directions of the police officer, right? But then everybody kind of follows blindly. That's kind of what the lymphatic system does. Once it's shown how to reroute itself, because it's a pretty smart system and it works off of siphoning and suctioning, it will follow that because it wants to go the path of least resistance. So that's what we're doing. We're rerouting it. So our techniques are very intentional, very specific to the patient's needs and where their dysfunction and functional lymphatics are. And it's just a different approach to treatment. So it's a manual technique versus a massage. Now, both have merit, but for patients with true lymphedema, they really benefit from manual lymphatic drainage. Long answer to your question, but I hope that makes sense.
It makes sense. And not only that, your answers to the questions are provoking more questions.
Oh,
so
good. Okay.
Julia Roderick, thanks for joining us, Julia, asks, so even the evidence of hypoproteinemia is just lymphedema?
It's even the evidence of hypoproteinemia is lymphatic fluid collecting in the tissues. So yes, it's all comes back to lymphatic fluid. Now, again, there's reasons behind why they might be having that condition or that disease state that need to be managed and identified. But the fluid that results is all lymphatic fluid. Now, it just might be a temporary transient situation that can be managed, like I said, through rest, ice, compression, elevation, or medications. Sometimes it needs to be medically managed. Or if it's truly the disease of lymphedema, then we need to appreciate that as well, because that's when there's true impairment or disruption. So, but all the fluid, just remember, all the fluid is lymphatic fluid.
So does the VAIL concept, which I loved, that was such a brilliant way, and that one slide, I just want to sit on that one slide with your quote. Does the VAIL concept mean MLD is actually indicated for any stage of CVI together with compression?
Great question. It would be beneficial really at any stage, particularly the stages where you see evidence of edema. But one of the things that they're starting to show through the evidence is, let's say somebody's going in for a total knee surgery. What some therapists are starting to do is they will do prehabilitation, well, they'll bring the patient in before surgery, do manual lymphatic drainage techniques and some central decongestion. So there's a whole bunch of stuff that goes along with that I didn't cover today, but they'll prime the system, right? And they'll bring them in ahead of surgery. Then they have the surgery, and then immediately after the surgery, they start the manual lymphatic techniques again. And what they're finding is reduced length of stay in the hospital, reduced amounts of swelling, or reduced postoperative edema, reduced postoperative debridement, and improvements in range of motion because the system's been primed. It's preloaded to handle the influx of that postoperative edema. So the same thing can hold true when you are working with patients that might have early stages of venous disease. Anything you can do to kind of prime the system and keep the system working and functional combining that with compression, so you get that activating that good muscle pump and getting people on a walking program is a win-win, because you're going to really help prevent for future complications, but hopefully slow the progression of that venous disease down.
And it's a perfect segue into a question about exercise.
Yes.
Does exercise refer to exercise of the edematous limb, or does general exercise help, even if it's not the particular limb that has edema that's exercised?
Great
for instance,
question.
Walking for patients with arm edema after lymph node exploration after breast cancer surgery.
Move to live, live to move. That's what we like to say. Yes, any type of exercise is beneficial. I love walking programs for upper extremity patients, lower extremity patients, and it's really finding what the patient likes to do. So to your question, will you get a benefit if somebody has upper extremity swelling or lymphedema and they're walking? Absolutely, because it's engaging the whole system. They're breathing, they're stimulating the diaphragmatic breathing, they're getting muscle pumping, they're getting suctioning and siphoning with the lymphatic system. But if the patient is able to do specific, and it can be basic exercises, just range of motion, or wrist pumping, elbow pumping, raising your hands above your head, using a cane or a wand, whatever you can do to induce movement is going to be beneficial. The key though is making sure they're doing it in compression, because you want the fluid and the muscles to have something to work against, so you don't bring all that fluid back. You want to contain it. One of the best exercises for patients for lymphedema, upper or lower, is yoga. If they can handle it, if they can do yoga. A hydrotherapy, working in a pool, swimming in a pool is excellent for these patients, and they can take their compression off to get in the pool and then put it back on, because you get hydrostatic pressure in the pool, which acts a little bit like compression. So find what the patients enjoy doing and just break it up just throughout the periods of the day. Don't tell them they have to go sign up at a gym or start some really aggressive exercise program. We're going to lose them. Just find little basic things that they can do, even sitting when the commercials come on. Just get up and walk around, or do some sit to stands, or raise your head, arms above your head, whatever it is. But the more that they can move and engage while wearing compression, the better.
That's such an important point about making it a manageable goal and
Yes.
starting where you're at. Every month we host patient roundtables at LymphaPress, and there was a lot of discussion last night at our lipedema patient roundtable of being kind to yourself. These patients have enough to deal with, and to make it manageable, bite-sized pieces, if you will. We have had stories of people that couldn't even walk to the mailbox, and now they're running triathlons, which that's crazy and inspiring, but just those small steps are so important.
You're absolutely, we have to meet the patients where they are. And the same thing is true with compression. I think a lot of people, quote, fail compression because we're doing what we think is the right type of compression for that patient, but it may be too much for them in the beginning. Yeah. So it's okay to start lighter and build up, or desensitize them and build up. It's because some compression is better than no compression. So just start with where they're at. A lot of it's just building their trust, establishing that rapport, making them or helping them understand in words they can understand why we're doing the things we're doing, and get them to be part of the process. And these patients usually are very, very responsive, because finally somebody's able to help them manage this condition. So
it's really inspiring to give people hope. And we still have a few more questions. You've been more than generous with your time, Dr.
Happy
Hettrick.
to stay. No
problem. I'm so glad, because we're going to keep going. And I think
From
our perspective at LymphaPress, we have seen in real time and clinically proven that the LymphaPress stimulates the lymph protein absorption and increases the lymphatic return during and after therapy. Sounds great, but in real life, patients can use it because it's easy to use. That's that other thing. We don't want to provide a therapy that is so complicated that it just sits in a closet somewhere. So we want to make it easy. It's therapy that's easy to live with.
Absolutely. Usability is key. I think of your TV. Now, how many of you have 6 remotes to work that TV? That's ridiculous, right? You need a universal that just has a couple buttons and that's it. So the easier we can make things, and the devices out there that have been designed with the lymphatics in mind are essential for this patient population.
Yeah. So John Beckwith has a follow-up question. Can you account for diffusion and peripheral venous return when you're saying all fluid is lymph fluid?
Can you repeat that? Sorry, I just want to make
I
sure.
would love to. Can you account for diffusion and peripheral venous return when saying all fluid is lymph fluid?
Yeah, and again, I think that speaks to there is a little bit of fluid which is going to be resorbed back into that venule end of the capillary, but under extreme circumstances, usually under significant trauma, significant stress, some disease states. So the process of that hyperfiltration or the hydrostatic pressure coming out, or the fluids coming out, the diffusion and the resorption is happening, but what it's being controlled by is the endothelial glycocalyx layer by mechanico-transduction, and then it's being picked up and managed really exclusively by that lymphatic system. So it's the dermal capillaries and the nodes in those areas that are picking up that fluid and bringing it to those regional lymph nodes to get cleansed, where it's ultimately getting reintroduced back into that venous angle. I hope that answered the question, but again, it really just comes down to understanding how that endothelial glycocalyx works, because that's really our gatekeeper for controlling the fluid movement out, and then the lymphatics are what control picking it up from those interstitial spaces.
Here's a compelling question from Olivia McKee, who is an occupational therapist and a certified lymphedema therapist. She had 2 referrals earlier this year of ladies that had 360, degree liposuction and Brazilian butt lifts in Florida, who were told to get lymphatic drainage to both describe a milking of trunk tissue, pushing the fluid out of the incision sites. Olivia attempted to explain what lymphatic drainage actually is, but they weren't buying it because their day after surgery was the pushing of fluid. It was frustrating. Any recommendations? And I hope that I read that properly, Olivia, for you.
Yeah, I think that's an example of good intentions with maybe not really understanding or explaining things very well to the patient. So again, anytime there's surgery, especially something traumatic like a liposuction or cosmetic surgery, the butt lifts or augmentations, things along that line, there's a lot of damage happening to those lymphatics, right? Because they're going in and they're removing. And if you've ever seen a liposuction technique, now not all of them, because some of the tumescent techniques that they're doing specifically for lipedema are very different. That's kind of lymphatic sparing, but some of them are not. And so I think what they're saying is that they know there's going to be a lot of trauma. They know there's going to be a lot of postoperative edema, which they're correlating with a lymphatic fluid. And they're saying if you can go get a lymphatic massage, it'll help clear some of that out. So I think that's what their intention was. I mean, I can't speak for them. And when we talk about milking, it's kind of trying to promote stagnant fluid to other parts of the body, trying to mobilize it, get it out there. And that's kind of the difference. I mean, lymphatic massage is just very different. The goals are very different. Just trying to mobilize the fluid. Whereas when I talk about manual lymph drainage, it's intentional to not just mobilize the fluid, but it also helps, because of the way the techniques are done, to help pick up those proteins, but direct it to functional areas. And those are functional areas that we learn to identify. So I think there's a little bit of a difference there. Again, I'm more of a proponent. There's nothing against lymphatic massage. I've had it myself. You have to drink lots of water because you're flushing everything out, but manual lymph drainage is very specific therapeutic technique to manage the disease of lymphedema. It's very intentional, it's very specific, and it's just utilized a little bit differently. So I think there's value to lymphatic massage, but I would just be careful. I wouldn't be using it really in my patients that truly have lymphedema, because they really need manual lymphatic drainage.
Excellent. So Sergey Grishinov, I hope I said your name correctly, says, perfect presentation. High praise. What does Dr. Hettrick think about the negative pressure treatment?
The negative, now I'm assuming you don't mean negative pressure wound therapy, right? You're thinking more of like the negative pressure chambers and things along that line.
That's what I'm assuming as well.
Okay.
But if you'd like to clarify, Sergey, please put it in chat so we can answer your question properly.
Yeah. Oh, like Lymphatouch or
Lymphatouch, yes.
Lymphatouch. Yeah, I personally, ironically, I haven't used it or lymphatic cupping. Lymphatic copy, yeah. Well, there's some devices out there that can provide a very big drawdown effect and stimulate the lymphatics. I think there's some that are a little bit more localized, like the Lymphatouch, that is very specific. I think there's value to that so long as it's being used properly and on the right patient population. I haven't used a lot of it, but I think like any device, it's an adjunctive tool that for the right patient at the right time can be very valuable. I do feel it can provide some benefit because it can target very specific areas. I think in those highly fibrotic areas, it could be very beneficial because it's harder to mobilize fluid under that harder fibrotic tissue. I just can't speak to it from personal experience, and I'm sorry for that, but I do feel that there is value to any type of negative pressure. In fact, that's kind of what we're doing with diaphragmatic breathing, is creating a negative pressure intra-abdominally to stimulate that thoracic duct. So I think there's a role for negative pressure in wound, and not just in wound therapy, that's a different thing, but for lymphedema as well. I personally haven't used it. So I would recommend reaching out to the reps to get a demonstration and look at the evidence to see what it has to say. But I do believe there's value.
So the topic of turtles.
Yes. White turtles.
Okay. When this question came in, I'm like, what? However, this apparently is a specialty of yours. Would you come back and talk to us in another webinar about turtle lymphatics?
I certainly will come back and talk to you about turtle lymphatics. Yes, and there's actually a connection between turtles and space, believe it or not. So I'd be happy to do a talk on that for sure. Absolutely.
Well, I'm glad we recorded that because I'm going to hold you to it. Dr. Hettrick, you're amazing. It's been an honor and a privilege to have you participate in the LymphaPress educational webinar series. And I also want to give an emphatic thank you to everybody who logged on. Your questions were amazing. Your chat was inspiring. I love the community that has been built where we sort of link arms together and learn together to affect change and to help people. And I would be remiss if I didn't close by saying, if you have a patient with lymphedema or lipedema, chronic venous insufficiency, or if you are a patient with any of these conditions, it would be our honor at LymphaPress to help you. Our therapy is built for real life, yours. So please do reach out. My name is Brenda Viola. You can get me at bviola@lymphapress.com. Everybody, you're going to get a link to this recording after the fact. And Dr. Hettrick, I hope you can hear the applause all the way in South Florida.
Oh, thank you.
Appreciative.
Well, thanks for spending your afternoon with me, everybody. Take care. Thank you.
This is amazing. Have a great day, everyone. Thank you.